So we're going to talk about basically TAVR, transcaval TAVR. The only thing unique about this case is that this patient had duplicated the IVC. So she is very present lady who is actually 4'2", and who's like 356 pounds. And that's important because it's limited some of other options. And she had BMI of 45, who had severe, she's known actually to have severe peripheral vascular disease, and we intervened on her in the past for peripheral vascular disease. She had diabetes, hypertension, hyperlipidemia, and as well as diabetic ulcer. She was known to have aortic stenosis for many years, but it became very symptomatic even at rest. She was not even able to go to the bathroom, so that's why she decided finally to let us do something for her. So that's her risk profile. As you can see, actually, her STS is not that high. She actually probably in the lower intermediate risk there. However, as I said, frailty, she was 404, and she had very elevated BMI. I think I'm going up here. EKG is generally okay. As you can see here, her mean gradient was elevated. She had velocity of 4.7 and mean gradient of 50. So she could have gone either 23 S3 or 26 evolute. Secondary to her peripheral, which I will show you, we decided to do transcaval, and we ended up choosing to do S3. Coronary evaluation, the only thing actually was significant was one smaller diagonal branch, which have 95%, but the vessel was like 1.5, so we left it alone. So the CT, she had actually heavy calcification in the ascending aorta. That limited, and she also has severe peripheral vascular disease in her on both sides. So you can see here that she had diameter on the left common iliac artery. She had diameters of 4.4, and she had the right common femoral artery was actually occluded. So both sides were not an option. Subclavian was probably an option. However, secondary to her short status and obesity, it was really very, very, very far from the service. So the surgeons did not feel comfortable actually doing it. So when we did the workup here, you can appreciate the double IVC here. And you can see here the renal arteries. And I'll show you another picture with angio and another picture with CT in a little bit. So as you can see here, there's two IVCs, and this is the aorta. So if we get closer here, you'll see that the area here is very close to the renal arteries. And you see all this calcification. You see this branch here. So we have very short target there to do our transcaval, but we felt this is really the only option we had. So we already planned for closure and bailout strategy. We already have a plan for Goessl expanding because it will go through 8 to 9 French sheet, which will go through that 4.4 millimeter iliac. So here you can see the angio again. And what you see basically here, this is vein number 1, vein number 2, and this is the artery. If you remember, the artery was completely calcified on this side. So the only area was this area here, which correlated with CT. So we were able actually to get transcaval access easily, and we'll see the closure at the end of the case. After that, basically, actually, it went very smooth. So we were able to deploy the valve. We did not have any AI. And she's very, as I say, she's short and she's very obese, so it's very hard to see some of the images. But when we do angio, you'll appreciate more. So basically, here, if we go back here, you see the angio here. We used a GLS sheet and deployed this disc here. And you can see some flow, not much there, but no extravasation of the artery. So giving all the calcium around this, we decided to balloon this and crush the disc on the arterial side, because we wanted that disc to be really very well opposed to the arterial side. We waited 10 minutes after that. We got very good results on closure, as you can see, and there was no residual flow. So we used figure of 8 suture on the venous side. And to be honest, actually, I think we wanted to use bare close at the beginning of the case, but her brain was very deep. We could not even get any flow. So anyway, we were able to achieve hemostasis using figure of 8 suture. So take home message basically that you can do Transcaval even if you have duplicated IVC. Thank you very much.
I just learned Transcaval cases because Dr. Greenbaum was at our institution and taught us. So one thing he said is, number one, is that 30–40% of people will have that flow, which is intentional, right? So
yes.
The first question would be, why did you think you needed to post that? Number two, your strategy of going relatively low in the aorta, he told us that you basically don't really have a bailout because there's no stent that really fits. How would you have saved that situation?
I'm sorry, the second question, I didn't get the second question.
So he said that if you don't have enough landing zone in the aorta above the bifurcation for a couple
yes.
you might get into trouble. So he doesn't like the lower sticks that you chose there. So how
yes, we actually reviewed this case with him, and this is the only case. So we reviewed this case with him. We did have a little bit layoff there to place the graft, but we had to be very, very precise. Okay. So that's one of the things. You're completely right. The only issue I think we have is we were worried that with the flow, we wanted to minimize the flow. We were worried here that figure of 8 may not hold. We have some patients who had some oozing before. If she was not obese, we would be okay because holding pressure and things like this will work. Here we were really worried because we have another patient who had lost, the patient did fine finally, but they lost like 3–4 grams because they were so obese, and that figure of 8 was not completely fine. So we actually started doing this balloon there, and you're right, and if you look at the registry, even I think the original first 100 cases, they have 60% flow. But many centers are doing this now. Our actually rate, we did I think 20 Transcaval so far, and our rate is only 5% because of this. Whether this helped or not, I don't know, but it's just, in this case, she's so obese, we were worried about bleeding, and we were worried about the figure of 8 not being enough.
So, obviously challenging femoral access in morbidly obese patients is extremely prone to complication. And congratulations, great work. The question that we have defaulted for those patients to, even if the iliac vessels are borderline, usually visualization is hard, trying to be precise is hard. We do them either subclavian, and if that is too deep, carotid. Right. Why not carotid in this case?
We, as a center, never did carotid, so we just did not feel this case. She had very short neck also, and lower verification, and we did not feel like this should be our first carotid case also. Yeah.
No, that's a very difficult case that you guys tackled. It becomes more and more apparent that the more patients we treat, the more patients come or discover that have so many other comorbidities that you obviously try to do your best to make sure you treat the one thing that you can. We've also tried to avoid the inguinal area for patients who are morbidly obese, just because they're prone to they basically be more prone to infections or things of that nature. But I think this was a very good case. Congratulations.
Thank you very much.
I'm curious. So one last question. So I'm curious about your closure device. You use the VSD occluder. I think classically they use PA occluder. Am I wrong?
Yes, we usually do. They were on back order, so also. Yeah, we actually, all our other cases, we use BDA occluder, you're right. Here we were on back order. I think another reason actually why we also did this, because we did not use the BDA occluder. I think that's true. Yes. Thank you very much.